All right, today is July 19th, and it's a pleasure to be with you all again. Um, it was good to have a little break personally, but on the other hand, I do find this to be a regular time that I enjoy, and as long as it's of benefit to you all, and I miss you. I hope you're all doing well in your prospective homes. So let's get started. I'd like to thank Terry Iman at the Lupus Foundation of America, Georgia chapter, along with the rest of the staff and the supporters there for their constant support of our program. So please keep in mind that the website and all the resources that are there that constantly live there related to COVID and unrelated to COVID that you can access. Also want to thank the Georgia Council on Lupus Education and Awareness, which is one of the very few states in our country that has a state supported council specifically on lupus. And it's run through the leadership of Chris Reed and Representative Kim Schofield, through the Department of Community Health, to focus on raising awareness, public education, improving access, and informing future public health efforts, as well as increasing appropriate diagnosis by non-rheumatologists. And the GOAL study, the Georgians Organized Against Lupus study, which has been funded for many years through the Centers for Disease Control and Prevention, run out of Emory. I headed along with Christina Drenkard and our staff, one of the lead staff being Charmaine Dunlop-Thomas, and it's really informed a lot in terms of worldwide understanding of lupus. But we have a very own large study looking at our own community and how lupus afflicts the people that we love and care for right here. So going into general COVID overview, these are the most recent numbers, and you can see that US is solidly remaining in the lead. Brazil is now number 2, India number 3, Russia number 4. And the last time I spoke to you was 2 weeks ago, and this was the map of the hotspots where the number of new cases have changed the most rapidly or increased the most rapidly. And it went from this 2 weeks ago, just to kind of give you a sense. Orange to red are the really rising areas. To this this past week, and you can see that really the US, a large part of Central and South America, South Africa and Russia, India, and along the Middle East are the ones that are really flaring up, if you will. This was the curves of new cases at the top and deaths in the United States as presented a couple weeks ago. And much like today, we were talking about how the first wave never really subsided. It was there, it just kind of flattened a little bit, never went down completely, and then it's obviously continues to go up. But that at least 2 weeks ago, we also noted that the deaths had not correlated with the increase in new cases, increased cases, in large part because many of the new cases were in the younger individuals, but it was just really a matter of time before more younger individuals had severe cases and they pass it on to individuals that are older with other issues that put them at higher risk for deaths and other poor outcomes. And so that's what we're seeing this week. We see the continued rise in cases, and what previously was a decrease in the number of deaths is clearly going up. And And this fits exactly with what we know about COVID, that the severity will lag about 2 weeks behind in terms of the number of cases that we are starting to see. So, with the rise in number of new cases, we see sort of a lag, but we are actually seeing the rise in in reported deaths. Certainly not as great as before, but again, it really adds up to a lot of issues. I mean, obviously death is the most severe outcome, but what this is also taking into account in terms of the new cases are a lot more that are going into the hospital and requiring ventilation and so forth. So this is a map of the hotspots in the United States as presented by us 2 weeks ago. And you can get a sense of how it's mostly back then in the West and clearly in the South, with pockets kind of in the upper Midwest and sort of the Atlantic, middle Atlantic areas. And here it is this week. And you see that the middle Atlantic, upper Midwest, and clearly the Northeast have gotten much better control over the rapidly rising numbers of cases of COVID, whereas you continue to see some areas in the Pacific Northwest, some portions of California, and especially around Phoenix. And then everything in the South is just bright red. And we've all heard about the huge numbers in Florida. And if Florida were a country in and of itself, it would be number 4 in terms of the number of new infections per day, with over 15,000 cases. This is what Georgia looked like 2 weeks ago in terms of hotspots, the rapidly rising cases being still in Metro Atlanta, but you can see the other parts, especially along the coast and some other rural areas. The Metro Atlanta counties have the highest numbers, some of the largest rates, but you see even though Dougherty County, even though it may not have the largest numbers per 100,000 people, it's still very high and much higher than some of the Atlanta metropolitan areas. And that was 2 weeks ago. And the map has changed to this. So we're just having rapidly rising cases throughout the state, clearly. So most areas, if not basically all, except for exception of very few counties that are very kind of sporadic, but the vast majority of counties in Georgia have an issue with rapidly increasing number of cases. And as I said, it's not just healthy young individuals that are relatively asymptomatic or have mild disease. This is being translated into larger numbers of people requiring advanced care. And this is the trend in terms of the ICU beds that are being taken up, and it's increased significantly over the past few weeks. And it's getting close to the 90% capacity mark, which is clearly in the critical area. So this is in the state of Georgia. And when we talk about metropolitan Atlanta, the top line here is the number of positive COVID cases in the hospital, which has gone up dramatically. And similarly, if you look at the ICU beds in the hospital, it's tracked along the other line, and it's now starting to go up. The ICU bed issue in Metro Atlanta is worrisome. It's not as critical yet, but it's clearly worrisome. And if we continue this trend, it's going to get to the point where you're hearing about in other parts of the country. So some of you may have heard about this document that was prepared for the White House Corona Task Force, but it was never officially publicized or released, but it was obtained by the Center for Public Integrity, and there was a lot of press about it. But it's a report, again, prepared by scientists for the White House Corona Task Force that suggested that about a dozen states should really go back in terms of their opening and be more strict with regards to protective measures, by enforcing masks, limiting social gatherings of 10 or more, closing really high-risk areas that include bars and gyms, and asking people to really stay out of the public. And this document was dated July 14th, so about 5 days ago. And it says about 18 states are in the red zone for COVID-19 cases on the left here, meaning that they had more than 100 new cases per 100,000 population last week. And 11 states are in the red zone for test positivity that you see here on the right, meaning that more than 10% of the tests that are being done are coming back positive. And so the document goes along, and you can see Georgia is red in both categories. It recommended that Georgia mandate statewide wearing of cloth face coverings outside the home. But as we all know, Governor Brian Kemp signed an order on Wednesday banning localities from requiring masks. And he continues to not require masks anywhere in the state. And so this lawsuit that he filed challenging restrictions implemented by the Atlanta mayor, Keisha Lance Bottoms, including her ordinance mandating residents wear masks to help stem the spread of COVID-19, is getting a lot of national press, and we'll wait to see how the courts play out, but most of us are very aware of this soap opera that is unfolding before us. So on the left here is the COVID hotspot map that I just showed you of the US, and on the right is where people are consistently wearing masks. The dark areas are the areas that there is a large percentage of the population, again, consistently wearing masks in public. And, it really doesn't take too much of a rocket scientist to see where the largest number of hotspots in the US and where the most number of cases are in the country clearly correlate with less amount of mask use in that same area. And again, you remember how New York and the New York City area and Seattle were in the news originally, and we're kind of looking at them from afar, having pity on them. But they have instituted, strict measures, and they've gotten much better control in those areas. And here we are just battling the blaze. This is a very interesting study to underscore the effectiveness of masks that came out just this past week in the CDC's main scientific publication called the MMWR. And this is a report of two hairstylists who were tested positive for COVID-19, but everyone wore face coverings. And of 139 clients, where these two COVID positive hairstylists who were just inches away from many of these clients, and they spent at least 15 minutes with 139 of them who were tested for COVID-19, none of the clients were positive, even after being literally face-to-face and having a hairdryer in their face and obviously talking. It's a very social environment. Nobody got COVID from these two positive COVID-19 hairstylists. So it really tells you that consistently and correctly wearing face coverings in public will do a lot to significantly slow the spread of COVID-19. And imagine what would have happened if there was not good protection and there was a mindset in this community and in this particular shop. Of these 139, a significant number would have been positive, and they would have gone home, and then those people would have infected others who would have infected others. And just to continue to remind us of the inequities that continue to rage along with the virus itself. And this was just recently published in the New York Times, and it talks about how different racial groups have a very different sort of distribution of who gets affected by COVID. And you can see in the white population that there is relatively fewer number of COVID cases in the younger, and you get a bigger spike as you get to the much older age groups. Whereas in Black and Latino communities, you have a very, in the Black community anyway, to start, you have an increasing risk from the get-go. All groups, by the way, are much higher than, are afflicted than the white population. But you see that in the younger population, going up in age, there's just a much greater chance or number of cases in the Black population, and it just continues to go higher and higher and higher. And then the Latino population, they seem to even sort of peak in the 50s, go down a bit, although still remaining high, and then going back up in the much older age group. Okay. There are a lot of hydroxychloroquine trials that are still ongoing, but there's much less enthusiasm for it because some of the earlier studies that have yielded results, and there have been a few, although there were some issues with how that they're not the most perfect tests or studies done, and we've talked about this in previous weeks. But enough consistency in the data that has come out have made people in general less enthusiastic about the potential of hydroxychloroquine for very, very sick COVID patients. Now, this is a study that was released recently that was done with a very good methodology, what we call a randomized double-blind placebo-controlled trial, and it was conducted in March, April, and May of this year. And it looked at symptomatic infected COVID patients who were not sick enough to be in the hospital. So relatively milder, non-hospitalized adults with laboratory confirmed or very highly probable COVID. That is, they weren't tested or they're not able to get tested, but extremely high risk with known exposure, and then symptoms within a few days after being exposed. But bottom line here was that hydroxychloroquine did not substantially reduce the symptom severity in outpatients with early mild COVID-19. So I think that sort of fits the more severe cases as well. It doesn't seem to have a strong effect, and that is what we see with lupus. The positive effects with lupus are not something that you notice right away. It's more gentle, if you will, and over a longer period of time. And so myself and others wonder whether hydroxychloroquine might have an effect if one were on it for a long period of time and on it before developing COVID. And we just don't have that information, and some of those studies are ongoing. And just to underscore, whatever rumors out there that may continue to exist that Plaquenil or hydroxychloroquine may have some level of protection, there's against COVID, there's absolutely no support for that. This is some additional information that was published out of that Global Rheumatology Alliance registry. And again, these are cases that are reported by either clinicians, and then they have a patient reported component as well. And it's not just limited to lupus. It's all rheumatology diseases, including rheumatoid arthritis, scleroderma, myositis, so forth. And it looked at the impact of biologic treatments. And biologic treatments are these medications that use biologic proteins and redesign them in a positive fashion to address disease. They're most often given through injection, IV, or under the skin through subcutaneous injection with a needle. Not all drugs given through the IV or injected are biologic drugs, but many of them are. So examples of biologic drugs include Benlysta or belimumab, rituximab or Rituxan. Those are probably two of the more common biologic medications used in lupus. Cyclophosphamide or Cytoxan given IV is not a biologic drug. But these biologic treatments do not seem to increase the risk of poor outcomes in individuals with a rheumatologic condition taking these medications. And in fact, there's some biologic medications like the anti-TNF medicines, which is a group that includes medicines like Enbrel and Humira, more commonly used in rheumatoid arthritis, although sometimes it can be used off-label in some people with lupus. Those drugs may actually even reduce the number that get into the hospital. Not enough to be used in COVID generally. It's just an interesting observation. But I think the main thing to really take away is that at least some of these new medications that manipulate the immune system in this way, there doesn't seem to be a signal so far in the data that we have from these registries and other observations that these people are at higher risk for COVID outcomes. It doesn't mean that you won't get COVID or you won't get sick, but at least it kind of reassures us that there doesn't seem to be a significant risk of poor outcomes if you do. Okay, so I'm going to jump into some questions. What is the hot spot? What are the hotspots of COVID-19 areas around the Atlanta area? I live in Douglasville, and I'm planning a trip to the fitness center where there are less people there. What do you think about that? In terms of the hotspots around Atlanta, I've showed you various maps today as well as in previous weeks. And with each slide, you can go back into the recording. I try as much as possible, if I lift something from a website or a source, I reference it in the bottom corner or somewhere on the slide. So if you are interested in getting updated information, maps, lists, and things like that I've presented, you should see a website where you can go back and you can go and see the different parts of the state. It's usually done by counties or zip codes. Unfortunately, we don't have more refined information like specific neighborhoods within zip codes, but you can get a general sense of your area and what the risk of community spread has been recently. I did quickly look at Douglas County, and it's sort of in the middle of all the counties in terms of ranking of hotspots, but that's not really saying much in Georgia, because if you remember that map of Georgia, practically every county is a hotspot, and so to say that Douglas County is ranked in the middle, it it just means it's a hotspot. And I think you have to keep that in mind. Number one, going into any public place about the general community spread, and because that's going to correlate with some increased or decreased risk that you might have. But also you have to think about where you're going to. And when you talk about a fitness center or gym, that report that I mentioned earlier that went to the White House Coronavirus Task Force that was never officially publicized. But this is an example for public messaging that they recommend for counties that are in the red zone or have a large number of community spread. And you can see a lot of what you would expect: wear a mask, limit social gatherings, social distance, protect people at high risk, and reduce your public interaction. But I point out here this third dot, and there's a reason why bars, nightclubs, and gyms are continually sort of pointed out in these high risk areas. And these are areas where it's difficult to protect yourself, and there's a high risk of other individuals not maintaining protective measures, as pointed out in the other parts of this slide. Bars, I don't think I really need to say too much. And then you add on top of that the demographic, the mindset, especially after some drinks, and it's a very social place. It's a difficult place to wear masks. Nightclubs, similarly. Gyms are tough, and even though there may not be that many people in the gym, from what I understand, I don't really go to a public gym anymore, but I've heard several people talk, those that have gone, just talk about how difficult it is. And maybe not for themselves, but for a lot of other people in the gym. And that's what you really have to worry about, is that there seems to be a lot of difficulty for people in general to practice these public health measures in a gym, especially the masks. I mean, when you're exercising and you're breathing hard and it's hot in there, it's hard to wear a mask, and people are touching the same equipment, even though you may try to disinfect. It's going to be tough. So, I mean, it's just a word of warning. I think it's just, gyms are tough, and then you put that gym in a red zone. It's a much higher risk than I think most people would want to have. There's three sets of questions here that talk about what's happened recently in the press. And I'll just pause briefly here for people to get a sense of what the questions are before I summarize them in the next slide. And also I wanted to point out to the individuals who took the time to formulate them that we've acknowledged it, and I've reviewed it, and I'm going to try to answer it sort of in aggregate here. So what those questions are about is with regards to the Trump administration recently ordering hospitals to bypass the CDC and send all the COVID-19 patient information to a central database in Washington, beginning this past Wednesday. And the move really alarmed a lot of health experts who feared that the data will be politicized or withheld from the public. And the officials, at least on the White House level, say that the change will streamline data gathering and assist the White House Corona Task Force in allocating scarce supplies like personal protective gear and some treatments that are very promising, or at least initially, against COVID for the very sick, like this medicine Remdesivir, which is going to be really in short supply soon. But the Health and Human Services database that will receive new information is not, supposedly initially, a lot of people were reporting that it was not open to the public, which could affect the work of scores of researchers, modelers, and health officials who relied at least previously on accessible data at the CDC to make projections and crucial decisions. And at least a lot of people felt that that was more secure and not subject to manipulation or being withheld or politicized. I'm not an expert in this field, but from what I do know is that the CDC director, Dr. Redfield, had a press release. It's like a media release, an interview that was on the CDC website, and you can see the link here. And basically, he said that the researchers at the CDC will continue to have access to COVID-19 patient information. And also, according to him and the CDC agency officials, despite the Trump administration ordering hospitals to bypass the public health agency and start sending data directly to HSS, that CDC will also have direct line of contact with that data. And the quote is, we have not changed the data ecosystem from the CDC director, Dr. Redfield. And this was on a call to reporters, from what I remember, and transcribed on this website. And he says that we merely streamline data collection mechanisms for hospitals on the front lines. So Redfield on Wednesday also said that CDC, as well as state and local health departments, will continue to have access to raw data through centralized database called HHS Protect. And that, quote, no one is taking access or data away from CDC. This access is the same today as it was yesterday, end quote. I don't know much more than this, and I did a quick search from what is publicly available. I think there's a lot of questions. It just happened a few days ago. This is clearly on the radar of the media and academia and public health officials. So I'm sure they're going to be under a magnifying glass, and you will hear a lot more. So you're seeing a lot in the press of very concerning statements and implications of what the White House is directing. But then you see these counter statements from Dr. Redfield sort of reassuring, but you don't know how much of this is politicized as well. So I'm somewhat in the dark as much as you. I just know that we, meaning the general public and the media, will continue to really sort of be on top of this. And the fact that there were 3 questions from you all on this I think is a reflection of how everybody else is viewing this with alarm and concern. And similarly, I think they're going to be watching it very carefully. So let's all together kind of see how this unfolds, and hopefully we'll know more in the future, and hopefully this will not impact negatively the flow of information and the accuracy of information that's out there. Does lupus make you at higher risk for COVID-19? There mentioned a test called a SUD rate. Right, and generally speaking, lupus is considered an autoimmune condition, and you're treated with medications that suppress your immune system. And people with suppressed immune systems with these types of medications are in a general category, as defined by CDC and many other organizations, as high-risk groups for severe outcomes if you were to get COVID. But your question is, are people with lupus at higher risk for getting COVID? period, regardless of whether it's more severe or not. And we don't have that information yet. I talked a little earlier about the question of whether being on hydroxychloroquine when you're doing fine and have been on it for a long period of time, would that have any impact on developing COVID? On the other hand, are some of these other medications that are being used in lupus, could that increase your risk of developing COVID? And then there are other questions such as, having lupus, you're much more attuned to immune issues. And obviously with COVID going around, most people like you all are going to generally be more careful. And so if we do see a decreased rate of COVID and lupus, I said if, we just don't know this information yet. Is that a reflection of people being more careful, or is it a reflection of maybe a protective effect of Plaquenil, or if people with lupus seem to get more COVID, is it a reflection of the medications that they're on? And everybody's on different types of medications and different doses. And as you all know very well, there's different degrees of lupus. Someone with mild skin lesions years ago is obviously much different from someone that has brain involvement, kidney failure, and a lot of other issues. So all this to say is, this is a very important question. I know it's on the minds of many, but we're far from understanding that. And it just shows you there's a lot more investigation, thoughtful investigation with your involvement in future research studies through GOAL and a lot of other organizations that will help better address these types of questions that are important to you. And that's what we need to keep in mind. That's always been the philosophy of GOAL, is that we depend on information coming from people, not just blood tests or physician-reported information. But we want to address questions that are important to you. So I just want to acknowledge that this is a very important question. I hear it a lot from people who live with lupus. We don't have any guidance, and we have no idea how different lab tests or medications impact that risk. So stay tuned. I read that Emory tested a COVID-19 vaccine, and early results show that it is safe and generates an immune response. Is separate testing for lupus patients necessary, or are we considered part of the general population in this context? Great questions. There are like 4 or so different immunizations being tested around the world. The one that's being actively tested that Emory and Grady are participating in is a vaccine out of Boston from a company called Moderna. And their results got officially published in the New England Journal of Medicine this past week. And as indicated here, the early results showed that it generated a robust immune response, which is what you want. You want the vaccine to then produce antibodies in your system, and it consistently generated a high level of antibodies against COVID, which we presume reflects protection. But that's another related question that still needs to be fully addressed. But that's a great first step. Now, the safety part, it was encouraging that even though, like all vaccines, and by the way, all medications that almost all of you are on, there's always going to be some potential degree in some people of some adverse events, some side effects, if you will. But generally speaking, I wouldn't call it safe or unsafe. I would say that it was reassuring that the numbers of reactions seemed to be generally mild and acceptable to most people. It wasn't anything scary yet. And it's always going to be something that they continue to monitor. They would never declare anything safe until all of the levels of study are completed. So this is just a very early phase 1 study. But again, these are all very encouraging results. And so they're moving it to the next phase, where I think they're recruiting about 30,000 people just for this study, to really get at some of the other questions, as well as to confirm what's been seen so far. Now, this next question is very interesting. And as I mentioned 2 weeks ago, I will eventually focus on this issue of vaccine because it's something that that in the general public there's an issue with. There are a lot of people that are concerned about vaccines. There's a high number of percentage of people in general, as well as people with lupus, that are afraid of vaccines, for some valid, but also for a lot of what I think are invalid reasons. But I think vaccines, just like medications, and this is why I keep repeating this, I don't think vaccines are necessarily in a whole other separate category. It's an intervention, it's a treatment, if you will, that works on your immune system, just like the biologic medications, just like Plaquenil, prednisone, azathioprine, methotrexate, and you all have a lot of experience with these medications. So just like any of these things, we have to know what these drugs do in people with, in general, whether they're safe, whether they do the things that needs to do without side effects, but also, are people with lupus same or different than the general population? And there is a theoretical issue with vaccines in general about the immune response. You want to induce an immune response, as it's in this statement here, by producing from a vaccine antibodies against whatever you're trying to vaccinate yourself against, right? So in this case, you want to generate antibodies against the COVID virus. So the vaccines will induce an immune response, a part of which is this positive effect of generating an antibody against whatever you're trying to protect against. But this immune response, if it's too much of a response, or if it's a response in a way that you don't want, especially if it's in a way that makes the lupus worse, or whatever immune condition worse, that's a theoretical issue. And so that's been in play for every vaccine that is out there. And I can tell you that the pneumonia vaccine, the flu vaccines have been shown to be consistently safe in this regard, meaning that there's no significant concern about people with lupus getting those vaccines and having the immune response be overactivated such that the lupus flares up and causes more trouble than it's worth. When one of the new shingles vaccines came to market, and the newest one doesn't have any live virus in it, but it does, which makes it eligible for a lot of people with immune diseases like lupus to get. So this new shingles vaccine is also thought was seen to be more effective than the older shingles vaccine because it did mount a much more vigorous immune response that produced the antibodies against the zoster virus or shingles. But with that, there was this concern that, well, maybe it may flare people up with lupus. And I know was it the most recent American College of Rheumatology meeting or the one before that, there was a presentation from a group. It was a somewhat smaller study, but it was a lupus-focused study of this shingles vaccine. And bottom line was that in people with mild and stable lupus, which I think is going to be the general theme, because anything that you do to sort of increase the immune response in a positive way for a vaccine should generally be given to people with lupus that are stable. You don't want somebody whose lupus is extremely severe and very active, with a lot of ongoing inflammation going on, a lot of strong immune suppressive medications being given to counteract that flare. I mean, you don't want to throw in a vaccine to try to induce an immune response for in a positive way in the mix in the middle of all that going on. So I mean, who knows what's going to happen? But it was reassuring that at least with this shingles vaccine in very stable lupus patients, that there was a very, very small risk of some mild disease activity in some, but for the most part, most people did just fine. So I think that is really what's going to happen when we get a vaccine for COVID, that you'll get the news for the general population first. And there will be this sort of outstanding question of whether people with lupus should get it or not. And it may take a little time for lupus specific, or maybe there'll be some early data with rheumatology patients where lupus patients will be part of the group, but not the only patients in that mix. But there will be some early information that'll come out to reassure or provide some guidance. But early on, there will either be no information with respect to lupus patients, or very little or indirect information kind of mixed with other rheumatology patients that guide about safety with the COVID vaccine. And it'll really be up to individual discussions between people who live with lupus and their physicians. And I can envision someone eventually one day coming to me and asking this question with the vaccine out there. And I'll, like I normally do, I'll tell the person what I know and what I don't know. And I'll probably at that point tell more about what I don't know than what I do know. But some people really will want to be more aggressive in terms of protection. Maybe they have older people that they're caring for at their home and they have to be out in the public with respect to their job, but they have extremely mild disease, no flares in a long period of time. Lupus markers are relatively lower. I think that would be sort of the lowest risk person to try it with lupus anyway, early on. So we'll see. But I think the answer to the second question is that I don't know about separate testing, but what we'll need is more information in studies even after a vaccine gets approved for the general population as to what may be some potential issues for lupus patients. But I'm sure it'll come out because this will be important for everybody, and we will want to have information as it relates to people living with lupus. I think this is the last question. Will you please go over the signs and symptoms of COVID? It seems like they keep changing. The signs and symptoms of COVID are not going to be defined by us humans. I mean, the reality is that the virus is what it is. People, there's a lot of variation in terms of what the virus does to people. And we know of people who are asymptomatic. So you can be infected and not have any symptoms at all. And then of the people who get symptoms, there's a lot of variability. And so this is a theme that we're all used to. Lupus is a clear example of this. And so just like lupus, we can talk about a butterfly rash and joint aches and swelling, hair loss, fatigue, and I think that represents the vast majority of you. But there will be a lot of people who just don't fit some or all of that, and yet they clearly have lupus. So this is what the situation is with corona. You can go to respective organizations like the CDC, and this is the website here on the bottom right, but you just Google CDC or WHO or other organizations. I think Emory has a list that references the CDC. But if you look at symptoms for coronavirus, and so these are the most common ones. And that's why we always talk about malar or butterfly rash, fatigue, hair loss, joint pains and swelling, and lupus, because those are the most common. And so these are the relatively more common symptoms of coronavirus. And I think it was 2 or 3 weeks ago that I mentioned that these bottom three were added because it seemed with as time goes on and we hear more and more about cases, even though these are less common than the ones at the top, they sort of rose in terms of numbers enough so that even though they were less common, they were common enough to at least be put on a list for people to be aware of. So I would know this small list well. And if you have symptoms like this, and especially if you're in a high risk environment or you've been around someone who's been exposed, you're going to want to have a very high suspicion of potentially having coronavirus. But know that, again, the caveat is that this list does not include all possible symptoms. We're learning more. I remember several weeks ago where I showed some pictures of some skin rashes that we were seeing that were very, not that common in general, but um, they were being seen in people with early COVID. So I think over time, we're going to learn more. But, the bottom line is, and this is where it's so frustrating for me and for many of you, I imagine, and so many other people. It's a shame that we have to worry about this symptom list so much because if we had a lot of testing that's available and that's quick to access, that's cheap or free, with results that come back very quickly, we wouldn't have to worry about this. I mean, we could have people that are asymptomatic and just regularly getting tested if you're in sort of a high risk environment. If you're home almost all the time and you're not around people, I mean, I wouldn't even get it unless you were outside or had a reason to. But if you're out in the public and you're in a frontline occupation, and even if you're not feeling poorly, you can get tested very regularly if we had that available. And to hear things like we're not going to be pouring resources and time into getting the testing developed and available across this country is just so frustrating for me, because that's where the answer is. We can't be sidetracked by all of this other stuff. I think we need to be laser focused on testing and getting that available and tracking when we can, because when we do identify people through positive tests, we can get them out of the way so that they don't infect more people. But the people that they do get in contact with, we can get in touch with them and test them quickly or have them sort of quarantine or isolate and get away from people. And that is the way, in addition to generally masking and social distancing, that we are going to just knock the heck out of this virus. It's so simple on paper. I know it's not necessarily easily done. I'm not saying it's the easiest thing to do to live life the way that we are doing, but the concepts are very clear. There's a lot that we don't know about coronavirus in a way, but there's a heck of a lot that we have learned. And it's, as I said before, it's a respiratory virus. It travels through droplets in the air and it goes into somebody else. There's ways to lower the chance of that happening. And we know how to test for this coronavirus if somebody's infected. Why can't we focus on those two things? Preventing its spread and testing. So off my soapbox and back to reality. The LFA is here, it's always been here. Please go to the resources, talk to Terry and the group there. We will, here's the website, here's the email address. Continue to send your questions. I think we're going to be on next week. Those of us at the GCLEA and GOAL, we will continue to represent you and fight for you, collect information, get studies and data that's relevant to you. And really, at the end of the day, it's a team effort. We're all in it together. whether you're on the left, literally or figuratively, or on the right. We're all Americans, we're all human beings, and we will get through this together. Let's see. So what are my thoughts and recommendations for teachers with lupus who will be heading back to the classroom? Do you feel that we can be adequately protected in a classroom setting with up to 25 young adults? Yeah, I think schools are very challenging. It's going to be a tough situation in general. It's not an easy thing. I know it's really couched with a lot of issues, socially, politically, financially. And something I was going to mention later, here's a resource for you. It's published by the National Academies of Sciences, and if you really want the full background and what we know and we don't know, it may not give you the exact answer to this question, but this is a very trusted source to gather all the information that we know as it relates to schools and school reopenings and how to do it and what to avoid in general. But I mean, going back to the question about if I had lupus and I was a teacher going in front of children, that's a really high risk scenario in my mind. I think it's going to be in general, but I think for someone living with lupus, it'll be tough. So if you can't avoid being in the classroom physically, I mean, obviously, ideally, it'd be great to just teach virtually, but if you had to be in a classroom physically, which PPE devices do you feel will be most effective? I mean, you have to focus on the kids and what the school is going to be doing, because remember, the masks and all that, the equipment are really, first and foremost, to protect others. So you can protect yourself very well, which I'll talk about in a minute, but you're really losing a lot if the others around you are not protecting themselves, protecting you from them. And so it's really whatever control you have in the classroom of making sure those kids are wearing the mask correctly and having a mechanism by which to really teach and enforce that, and having the school back you up with that would be key. Social distancing as much as you can, to the degree that you can, with the physical structure of the classroom and the hallways that you're going to be exposed to is key. In terms of what you can do, bandanas, no, it's not enough. The cloth masks, not ideal. It's better than the bandanas or some cloth covering. But the multi-layered cloth masks are second best. The surgical masks or procedure, and there's also procedure masks. I don't know how well the general public can get access to that. That would be much better, and they're the more comfortable ones to wear longer in terms of medical grade. So you may want to see how you can get access to a surgical mask ideally, or a procedure mask. They're the blue pleated ones with the loop around the ears. But again, there's a lot of counterfeit stuff out there. You kind of want medical grade. And really the holy grail would be an N95. And I don't think most people will be able to get access to that, because all the hospitals should get access to that at this phase. We don't have enough nationally to go around. The KN95 that you may have seen on advertised, they're basically generic versions, most or if not all. Maybe K by definition means that it's produced in China. But the KN95 theoretically meets the same requirements as an N95 mask. So if you can get a KN95 mask, they're not as comfortable as any of the other masks that I mentioned, but with a tight seal around and worn, they will protect for 95% of all the droplets that will come very close to you. The main issue, and I'm not sure how you would to really go around this is the main issue is that there are some counterfeit KN95s out there. So you could be buying something that doesn't truly give you that same grade of protection as medical grade N95 masks. So keep that in mind. You may want to look up or see what other chat rooms there are in terms of distinguishing that counterfeit or not. I should know better, but frankly, I haven't had to deal with that because I can get that at the hospital, and really generally in the public, I would continue to recommend the multi-layered cloth masks or the stuff that people are wearing out there. That's good enough for the main public, okay? So for most of you, I know I'm talking about the Cadillac of masks, the KN95 or N95s. You don't have to do a mad rush on that. Social distancing and the regular cloth masks are fine for 99.9% of you. But I think if you're a teacher sort of in kind of that aquarium or that bubble with kids who may practice various degrees of protection themselves, I think the best way, I would recommend trying to protect yourself the best that you can with that. If you're going to be really close to students, and I don't think you should be at all, ever, or with anybody, with any individuals, you should have sort of eye protection as well in terms of goggles or sort of a plastic face mask as well. But I mean, that's really getting to small numbers of people, maybe with very distinct occupational hazards and things like that. All right, I've gotten really long. I'm sorry, but hey, that's 2 weeks worth in 1 week, I guess. You get your money's worth. Hope you enjoyed the week without me, but I'm glad to be back with you, and thank you again for allowing me into your living rooms. Stay safe, and I'll see you next week.